Good evening, everybody. Thanks, respected chairpersons and add-ons at my dear friends Manoj and Purvi for inviting me over here. And can I have my slides, please? So I would be talking on guidelines for diabetic dyslipidemia, and a topic which is very pertinent, and with a great surprise, I am seeing still the number of people who are attending over here. So let me begin with a quote from Alvin Toffler, who states that the illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. And there are so many things which has changed in a recent past, which we need to understand, which is there. We know that India is facing a severe storm of cardiovascular disease, and we have a huge burden of the metabolic disease associated conditions, be it hypertension, diabetes, dyslipidemia, obesity, and the high prevalence of one condition is going to lead to the detrimental outcome. And all these are not only just additive, but the multiplicative factors play a role. And we know the attributable risk factors for first MI or a cardiovascular event as per the Interheart study. There are various risk factors, and one of the most important factor is dyslipidemia. So imagine a diabetic patient with dyslipidemia. What is the burden? It's a huge burden. And you look at this IDS study 2022 of newly diagnosed type 2 diabetic patients in India, and what it had shown that 60.5% were classified as very high risk, 82.5% appeared to have at least one cholesterol abnormality, and 96% presented with lipid values above recommended targets which are there. So we know the complete compendium, how there is a CV continuum which happens. So you have not just one risk factor, there is a metabolic factors. So you have a lipid, sugars, hypertension, and all leading to you have a concomitant end results. So where you are going to end up with a lipid abnormality and a vascular events, and we need to take care of those, which is very important over here. So the guidelines, when it comes to guidelines, how are the targets determined? So it's not that somebody just comes and talks, okay, no, you need to achieve these targets. It's an evidence-based approach. So LDL targets are not just arbitrary. It is population studies which has been analyzed. There are various randomized clinical trials which has taken into considerations, meta-analysis which has been studied, and there are various genetic studies, and then there is an expert panel discussing and coming out with the guidelines that okay, these are the recommendations which should be followed. So now before I begin, can anybody tell me what should be the targets for LDL in a diabetic population? Is it very good? So for the first time in 2019 in international guidelines, European Society of Cardiology came out with the risk stratification. So if you remember when we, a decade back, it was a standard line that diabetic dyslipidemia means you target LDL at 100 milligram per DL. So gone are the days. Now you need to risk stratify, and what it has been shown over here in 2019, for the first time they risk stratify, and depending on the risk factors, if there is a moderate risk and younger patients, that is type 1 diabetic less than 35, type 2 diabetic less than 50 years, and diabetic duration less than 10 years without any comorbidity, they come in moderate risk, and their target should be at 100. Otherwise, high risk means diabetes without target organ damage, but diabetic duration more than 10 years with additional risk factor, it is high, which is 1.8 millimoles per liter, which comes to around 70. And very high, where diabetes and target organ damage more than 3 major risk factors, or early onset diabetes with long duration, it comes as very high, which is equivalent to target should be 55. So this was started in 2019. So moderate risk LDL target less than 100, high risk less than 70, very high risk less than 55, and then even they have gone that with recurrent events you can go even less than 40 also. Now, for the first time, our own Lipid Association of India, which came out with the expert consensus statement on management of dyslipidemia Indian, it was in 2016. That was the part 1 came, and then there was a specifically for management of diabetic dyslipidemia in Indians. And this was the expert consensus statement from the LAI, Lipid Association of India. It has come. Now, look at them. They have modified over a period of time. The last one, which has come in 2024. Now, I want you to focus. There are 5 categories: low risk, moderate risk, high risk, very high risk, extreme risk. This is, we are talking of general population. But look at diabetes. Irrespective of the status, first a minimum come as a high risk category. So they come with 0 to 1 major ASCVD risk factors. Now, if they have a target organ damage, they will come as a very high risk. If they have got a more than 2 major ASCVD risk factors, again they will come as a very high risk, which is there. So you need to understand now, no more they come in the category of moderate risk, they come in the category of high risk. And what are the treatment targets for lipid lowering therapy for these groups? Now look at it, as I have mentioned, it is high risk and very high risk. So for high risk, less than 70, so it is not even 100. Now the recommendation is target of LDL less than 70, non-HDL cholesterol less than 100, and ApoB less than 80. For very high risk, again it should be further lowered down, LDL less than 50. Obviously for non-HDL you add 30, so it is less than 80, and ApoB is less than 65. And these figures you should be keeping in mind. So I have simplified this, the guidelines which is given. So you see it, diabetes, is it without ASCVD or diabetes with ASCVD? Without ASCVD, no target organ damage, high risk, LDL goal less than 70. Even they have a target organ damage or more than 2 ASCVD, very high risk, LDL less than 50. Now, diabetes with ASCVD with associated comorbidities, they come in extreme risk group category A, LDL goal less than 50, optional is less than 30. And now for the very first time, this is the additional group which has been put, diabetes with polyvascular disease or target organ damage. So somebody who had a stroke in the past, acute coronary event in the past, they come extreme risk group category B, where LDL goal less than 30. This is what we are looking at it. Now, this is when we compare the ESC guidelines versus LAI with American Association of Clinical Endocrinologists guideline. If you see, the LAI don't put the diabetic population in a moderate risk. It straightforward comes in high risk, and now same is endorsed by American Association of Clinical Endocrinologists also. Now talking about the CSI, Cardiological Society of India Clinical Practice Guideline, they came in 2024. Even they have put diabetes with 1 or more risk factor as a high risk, and diabetes more than 20 years with multiple risk factors or target organ damage as very high risk. Now their target is little different. Instead of 50, they are saying less than 55. And for high risk, it is less than 70. Now RSSDI, consensus recommendation in diabetic. So again they talk of same high risk, very high risk, extremely high risk less than 70, very high risk less than 50, and extremely high risk less than 30, which you should be taking in mind. Now what are the guidelines specify about the statin dosage? When you say the high intensity statin, which are only Atorva 40 to 80 and Rosuva 20 to 40. Moderate intensity statins, you have varying dose of other statins also. And then you have a low intensity statins which just reduces LDL by 30% also. So algorithm for going is, when you want to treat it, start with high intensity statin. You have optimal control of the primary factors, reinforce the lifestyle measure, which is equally important. And if LDL-C level, when we are talking of a very high risk, you need to use other therapies also, which includes ezetimibe, bempedoic acid, PCSK9 inhibitors, or monoclonal antibodies, which is required also. And this is a beautiful paper which has shown the intensity of pharmacological LDL-C lowering. You might be wondering, can we reduce it? Yes. You use the statin, you have a reduction. So moderate intensity statin can reduce 30 to 40%. High intensity statin reduces 40 to 60%. And when you add on with other therapies, yes, it will have a further reduction also. Now, non-HDL cholesterol, so there is now the more talk has been given about the non-HDL cholesterol because it's a superior marker. It includes total atherogenic dyslipidemia component, and that is why the recommendation is, rather than only considering LDL, look at the non-HDL cholesterol. Plasma triglyceride, we know that it is associated with increased ASCVD risk, 32% increase with per 1 millimole per liter increase in men and 76% in women. This is as per the meta-analysis. And hypertriglyceridemia itself is a marker of insulin resistance, glucose intolerance. So you cannot ignore this hypertriglyceridemia also. And what is the recommendation? That is one point which you need to keep in mind as per the LI recommendations, that if the triglyceride is 150 to 199, again you need to take care of the lifestyle measures and the dietary modifications. When it is 200 to 499, you primary still should be targeting at LDL cholesterol, and that is where the statins come into role. But when the triglycerides are more than 500, you should be using therapy which is specific with the triglycerides. So besides the intervention in terms of lifestyle, fibrates, omega-3 fatty acids, and then adding another drugs which will be of relevance, which is very important also. And what are the medication? These are the drugs which can reduce the triglyceride levels, which is you will have to keep it in mind. Now here I want to show few real case scenarios of few patients. Look at it. Now this patient, if you look at only LDL cholesterol, you will be very happy. But look at the total lipids, that is total cholesterol 618 with triglyceride of 4732. Will you leave this patient like that? No. Now other values. Here look at the patient, same time, HDL and LDL, both are equal. So you can achieve these levels also. Look at this another patient. Now here it is very rarity. HDL is more than even LDL cholesterol. So this is achievable, doable. When you think it's an extreme high risk, it is doable. And the last one which I have shown just to give you an example, look at this number, what they said, LDL is minus 45. This is because when the triglycerides are more than 500, if they calculate it, they will not get the right figure. They may not able to give actual measurable LDL, and that is, it will give a faulty reading. So quarter of a century of treating LDL, the dictum has changed. Earlier it was high is bad, then average is not good, lower is better, even lower is even better, and lowest is the best. So that is the formula we should be using. Ladies and gentlemen, to conclude, diabetic dyslipidemia remains a major risk factor for ASCVD. Lower LDL is better for reducing CV risk. No minimum threshold benefits persist even at LDL less than 30. Large trials and meta-analysis have shown safety and efficacy of aggressive LDL lowering, and non-HDL and TG should also be considered and kept at a target range. I would end with a Chinese proverb, meaning superior doctors prevent the disease, mediocre doctors treat the disease before evident, and inferior doctors treat the full-blown disease. We Indians are far superior doctors than our counterparts in the West. So let's be proactive, go for a preventive strategy. I invite all of you, we have a last slide. Can I have last slide? The Lycon International 2025, which is happening in September 5 to 7 in Delhi, and we have a Maharashtra State first Mahalycon, which is happening on 12th October at Nasik. So would request everyone to join for it. So proud to be Indian. Our Indian guidelines has come. Thank you so much for your patient hearing.